I would also, the current Sedasis device does not turn off Propofol for hypotension. You have to do it yourself. But in the ED, when you're dealing with trauma, you might actually want that. Person starts to have blood pressure, you're not really sure where they're bleeding from, you might want the device to say, hey, we're going to start Propofol alarm a lot. So they may want to have additional controls. I think ICU physicians may very well want this. It's going to be approved for all ICU procedures. In their case, top of their list, all I put at the bottom of mine, was choice of drugs. They'll probably want propofol and they'll probably want dexmedetomidine. Why not give both drugs? Make the device suitable so you can give one or the other. It will have wide dosing limits. Once again, it will tend to turn off propofol by default for hypoxia, hypoventilation, but this can be overridden. Why? Because the patient may be on a ventilator. So you need to have the ability to override these. I think maybe even for pediatric sedation, there's a huge need for improvements in pediatric sedation. Almost nobody pays any attention to it. But I think in this case for kids, and again, I'm not a pediatric anesthesiologist, so I defer to my colleagues who are, but my view is that you would have very narrow approvals, which would be evidence-based. In other words, you have to look at different kinds of procedures. Is this device safe in individual procedures? You'd have tight dosing limits. In this case, TCI is mandatory. Why is TCI mandatory? Because with adults, one size fits all, it's not so bad. But kids go from this big to adult size. And you really do want a system that understands and gives propofol optimally, ideally using the pharmacokinetics that Professor Streese has put together with Professor Eleveld if they're here. So there will be, I envision it being a TCI device. It'll have a hair trigger for hypoxia. Little kids don't tolerate it really well. Hypoxia, hypoventilation, a hair trigger on that. But on the other hand, the loss of responsiveness, that's going to be optional because it's going to be a little hard to explain to a 2-year-old to squeeze their hand. And even if you tell them in the earpiece, it's not likely to mean much. Finally, you may want this for pain management. Really? Is there a role for propofol in pain management? Well, it turns out there are actually a bunch of studies in animals looking at propofol in pain management. There are a bunch of human studies. I have a little, you can't read it here, and it's just as well, it's just gibberish. But basically, there are a number of studies showing that propofol does work in certain chronic pain conditions and in headache, in migraine. And just by way of a plug, I have to highlight one of Pamela's papers that came out just 2 months ago in JPET. And what they found, which is pretty cool, is a role of propofol in chronic pain for mechanical hyperalgesia and thermal hyperalgesia. In the interest of time, I'm just going to drag on. What we're looking at here is basically different levels of stimulus intensity, and this right here is the paw with the incision, and this is the contralateral paw right here. And what you can see is a very clear dose-response curve for propofol, decreasing the responsiveness to pressure, and also similarly, if you look at a temperature stimulus in these incised hind paws, as you give more propofol, basically the paw with the incision starts to become indistinguishable from the other paw. And so propofol may have a role in pain management. So you would use this for chronic pain management. You would obviously limit this to stuff which isn't responsive to any other therapy, because long term, this would be something to sort of tide someone over while you're finding other modalities that may be helpful. If you're going to be doing, and you also would limit this to subhypnotic doses of propofol. We wouldn't even be talking about minimal sedation here. These are really subhypnotic doses because that's the doses that have been found to be useful in pain management. I think this might, in fact, be something that would be used on an outpatient basis. If that were to be the case, you'd absolutely have a hair trigger for any patient compromise. Any suggested patient's compromised, boom, it's turned off. And that would be mandatory. And if it's going to be used in that kind of outpatient basis, you might even put some sort of telemetry, internet capability on it. And you might even have certain kind of lockouts depending on what's found to work. It's hypothetical, but there is potentially a role for propofol infusions in pain management. How about for palliative sedation? Really? Use propofol for end-of-life care? Well, it turns out this is actually a very big issue. Here's a literature search looking at articles on continuous sedation up to the point of death. And this is not supposed to be the GI suite, don't get me wrong here. So that was some of the other speakers. No, this is continuous sedation in terminally ill patients. And it's a growing topic that maybe we should be providing this to patients so that they can be comfortable, just like we look after analgesia. And there are some articles in the anesthesia literature, although most of them, of course, are actually in both the medical literature and in the medical ethics literature. It introduces a whole bunch of words. I mean, I just learned about this the last couple days, like on the train up here. Single word for it it's called sedation. There are two words for this end-of-life sedation. Sedation-induced sleep, I don't really know quite what that is. Terminal sedation. This one I find a little spooky. Slow euthanasia is what some people call this. Palliative sedation, total sedation. I mean, I guess that means like it goes all the way down to your toes. Sedation therapy, there's controlled sedation as opposed to uncontrolled sedation, and there are even three words. This is a whole article, by the way, that introduces these terms. Total pharmacological sedation as opposed to like hypoxia, I guess. Palliative sedation therapy, early terminal sedation. So we're going to get them early. And if you don't get them early, it'll be end-stage palliative sedation. I mean, be on the lookout for these words. But I think there's a role for this. Once again, I envision it would be limited to subhypnotic doses of propofol. I think you'd have programmable responses for these things. Because it may be that if you're trying to keep somebody comfortable, and every time their sat drops, you turn the propofol off, well, that might not actually be in the patient's best interest. You'd have to figure out how to do this in a way that was safe and, most importantly, provided the goals at that point in the person's life. I do think TCI would be very helpful in this, and my guess is in this kind of computer-assisted propofol or personalized sedation, you might allow patient control. Very much along the lines of existing patient-controlled sedation. There is this whole concept of patient-controlled sedation. You're a little too awake, you push the button. Maybe this would have that kind of feature in it. Finally, there's computer-assisted sedation. P was for propofol. P might also be personalized, but in this talk I've used P for personalized, for propofol sedation. But computer-assisted sedation with other drugs other than propofol. Doug Raines and his group, Stu is here, at Harvard, has done wonderful work. I don't have mock carboautomated up here, but they've got a whole series of beautiful automate analogs that they've worked on. These might be much more logical drugs because you turn this off and you don't have to wait 3 minutes. What, a minute? And they're gone. There's remimazolam. There's a drug that AstraZeneca was looking at for a while, AZD 3043, another ester. So these other drugs might have a role in these devices. And when you turn it off, these ones are gone even faster. So I've talked about some of the things, but there is one other thing I want to get to, which is really the question that everybody in the room wants answered. You've been kind enough not to ask it, but this is the question everybody in the room wants answered about sedasis. Could sedasis have saved Michael Jackson? Well, I've thought about this. And I think the answer to this question is no. The reason I think the answer to this question is no is that Michael Jackson wanted to be unconscious. And he had a really serious sleep disorder. Every time he would start to stop squeezing that button, it would turn the propofol down and eventually off. And that would just make him furious because it wasn't what he wanted. So sedasis would constantly have been turning the propofol down. It would have prevented him from entering deep sedation, and it looks like he essentially needed general anesthesia to fall asleep. So basically, it wouldn't work. It just flat out wouldn't do what was needed. Now, I've talked about a hypothetical device, like an anesthesia, a version of Sedasis with an anesthesiologist mode. You know, you kind of push the button and all the controls go away. And I point out here, there is no such mode on Sedasis, so this is a hypothetical device. But if there was a device with an anesthesiologist mode, so it turns off all the controls, turns off all the feedback, it still wouldn't have saved Michael Jackson. Why? Because it requires an anesthesiologist. That's the whole point. If you're going to turn off all the controls, you're not going to have any of this feedback. You're not going to have any of these dosing limits. You're not going to have it push back when you start to get towards deep sedation. It requires an anesthesiologist in the event of an overdose. And to the best of my knowledge, no anesthesiologist was present. So with that, the future of propofol sedation. Sedasis has finally arrived. This is the first FDA-approved device to integrate drug delivery of a hypnotic with measures of patient physiology. It extends our standards of patient safety to all the patients in the clinic and in the hospital, at least to all the GI patients right now. Hopefully, eventually, all patients can benefit from this technology, because the vast majority of those patients don't see us anyway. I think this presages a new generation of devices to increase the safety of sedation. But I emphasize that it does not and it will not replace anesthesiologists. When we need to be there, we need to be there, with or without Sedasis. Thank you very much.
Thank you, Dr. Shafer. That was a great presentation. We'd like to invite our panelists to come up, and now we'd like to entertain questions from the audience on our topic of discussion. Dr. Rosso, let's start with you.
Can I respond to that first one? And that is, as you know, we've modeled both of those. And the interaction with midazolam and opioids is actually a little bit stronger than the interaction of propofol and opioids. Is anybody here from Al Dahan's lab, by chance? I don't know if Al Dahan has specifically looked at that for respiration. We looked at it for loss of consciousness.
The other issue, the decision to use supplemental oxygen when oximetry is the endpoint. There's a lot of argument over whether or not that's a good thing or a bad thing. That you're obviously increasing the safety if the person gets into trouble, but you're decreasing the sensitivity of that monitor. So the decision to use that particular amount of oxygen actually could have a big influence on the overall safety. But the last point, when I looked at the data that Talmadge presented, there were outliers. I don't actually care if the average dose is 50 micrograms per kilogram. I do care that some of them were 100. And what I care about are the outliers and whether or not a person accidentally goes into a general anesthetic. From what you showed, that occurs some of the time, although in the database you analyzed, no one got into big trouble. So the question is that a real estimate of how often that's going to happen, and how often can we get a person who's potentially going to be overdosed?
I'd like to just briefly reiterate the question for the people in the back. Are you able to hear okay? I know we don't have a microphone. Okay. Take it away, Dr. Egan.
So the first question with regard to the supplemental oxygen administration, it's a fair question, and it's conceivable that some of the outcome is a function of the oxygen administration in both groups. But my view is that the affecting the sensitivity of the oxygen measurement or the pulse oximetry in detection of trouble in the presence of supplemental oxygen is really only a problem when you're not measuring ventilation separately. And when you have a sophisticated measure of ventilation separately, then it's sort of stupid not to give oxygen, in my view. You know, the whole argument for not giving oxygen is just because it delays the detection of apnea. But if you're measuring, if you're monitoring that in a more sophisticated way, then I think it makes sense to give oxygen. It just increases the overall safety. But you're right that it's conceivable that some of the outcome difference was a function of just the additional oxygen. And then the second issue with regard to the outliers, I think you're absolutely right. When you increase quality in healthcare, really what you do is you rein in the outliers so that the outcomes are more predictable and there's less of a distribution, because it's the outliers that are troublesome, that are dangerous, that are expensive, that have catastrophic outcomes and so on. And I think this data overall is fairly tight, but certainly the FDA scrutinized outliers, and some of the cases that were examined in great detail sort of address some of the concerns that you raised. And a key finding was that none of the patients in the CAPS group, yeah, you might want to show that slide.
Computer.
None of the patients in the CAPS group actually, who suffered deeper than intended sedation, had any respiratory morbidity. So that was a very important finding.
What's interesting, and we've all seen this in our practice, is the patients who stop breathing are typically the patients who are sedated and then they get a little opioid on top of it. And that's really the bad actor here. This right here looks at all of the patients from the pivotal trial. And this right here shows now it doesn't show anything, just a moment. This graph right here shows the sedation score. These are the patients who had transients where they were scored at a 0. I have to mention this was scored with a trapezius squeeze. And a trapezius squeeze is a very, very non-standard test. So some of these patients scored 0, and then a minute before that they were talking, and a minute after that they were talking. So it's a little bit questionable whether they were actually there. But to your point, deeper than suggested sedation, this on the top graph, same patients, they're all sorted by their AUC DSATs. And this looks at all the subjects. This just looks at the subjects who actually had a DSAT other than 0, because in both groups, most of the DSATs were 0. And the amazing thing is it had nothing to do with the level of sedation. People would talk to you and they would not be breathing. And this audience sees that in your practice every day. So it is amazing. Fortunately, when they're talking, they're at least moving air. But you might expect, like this is a patient with deeper than intended sedation in the standard of care group who had a DSAT. But the highest DSATs here are actually associated with people who are not very sedated. So your suggestion of going to 100, gee, aren't they too much? I'm concerned about the outliers. Are they going to do worse? It's not supported by the data.
Well, I think you're right. I mean, the question always is how generalizable is the pivotal trial out to Main Street? And that's why the post-approval study will be important, to gather data that supports the findings of the pivotal trial. Of course, yeah.
Of course.
So, if I can comment, the technology is amazing, and technology is a form of power, and it can be used for good, and it can be used for not so good, right? We all know cell phones and smartphones are great, except when people are using them while driving. Somebody used this as an illustration. And we also heard how gastroenterologists make decisions that are not
I mean, let me just say that obviously training is
Yeah.
going to be critical. And part of the unmet need in this area is some type of standardized training that is the basis for credentialing and privileging, so that you can be confident in your institution that people that you're granting those privileges to have some basic understanding of sedation practice,
So
especially as it relates to preoperative evaluation.
to that point, this is an opportunity to advance care. GI physicians are making these assessments today because the risks with midazolam are not lower magically, and they're making these assessments, and sometimes they're not doing all that well. And I don't know about your hospital, but I'll tell you at Stanford, you know, there's a code blue in the GI suite, you know, every other day. And